Dr. Raymond, as always, we deeply appreciate your willingness to check in with us and give us a good situation report on COVID and the vaccine. And so the floor is yours.
Yeah, thanks, Steve, and good morning, everyone. I know that there will be questions about the Johnson & Johnson vaccine and potential side effect of blood clots. So Chris Jenkins is going to put a couple of links in the chat box that you can cut and paste if you want to take a look at guidance from the CDC and from the FDA. There also is a statement that was released this morning from the Wisconsin Department of Health Services that should be available on their website. With that, I'll just go ahead and start with our usual report. Chris, if I can go to the next slide, please. The number of daily positive cases continues to rise slowly. We were at 402 positive cases yesterday in Wisconsin and 115 in Milwaukee. These numbers are higher than what we saw in late January, February, and March. The case positivity rate also is going up. In Wisconsin, yesterday it was 12.7% and 17.1% in Milwaukee, with the 7-day averages off to the right there very similar. So the trend is unfavorable in terms of case positivity. Just to put these numbers in perspective, we're approaching 600,000 total cases in Wisconsin since the beginning of the pandemic, a little over 13 months ago, and you can see that in the right-hand green bar. And we've already exceeded 100,000 cases here in the Milwaukee area. Also, to put things in perspective, we peaked at nearly 8,000 cases on a single day in mid-November in Wisconsin. So even though we are seeing an increase in the number of positive cases that we have, we are not right now in what I would characterize as a surge, although there's a clear upward inflection which could result in a surge if the variant strains take hold or if we relax our personal vigilance. So I go to the next slide, please. Just want to also just talk a little bit about the cumulative deaths. We're approaching 6,700 COVID-related deaths in Wisconsin. And as we've talked about in the past, the COVID-19 deaths and severe disease disproportionately impact males and people of color. And you can see that as an overrepresentation of deaths compared to the population at large in Wisconsin on the left and in Milwaukee on the right. Now we are approaching 1,300 clinical and PCR diagnosed COVID-19 deaths in Milwaukee. That number is higher than the medical examiner's report, which usually goes with autopsy confirmed deaths. So I just want to make sure that, you know, we've had far too many deaths, and that although our numbers of deaths still remain low, remember that deaths lag increases in cases by somewhere between 4 and 6 weeks. So it's really going to be important that we follow that death trend out a few weeks from now. Next slide, please. Thank you. I just want to give you some key takeaways today. Wisconsin is doing better now than we were during the first 3 surges. And I would say the surge in the spring and the summer of 2020, in retrospect, those surges were relatively mild. The surge that we had in November was quite significant. We came perilously close to overwhelming the capacity of our health systems to take care of people with COVID and other diseases at that time. And we certainly enjoyed a significant downward trend from November, but the cases and hospitalizations in Wisconsin are rising, and they have been for the last 2 weeks. Our cases are averaging now 789 per day. That's a 7-day average, up from a low of 363 on March 11th. And our hospitalizations also are up 50% since we reported a low of 193 hospitalizations on March 21st. The 7-day average for new US daily cases shows similar trends. We have a rise from under 50,000 per day in mid-March to 69,632 7-day average reported yesterday. And hospitalizations also are up 9% in the US. However, the deaths in the US are still trending slightly downward, again, possibly reflecting the lag that we've seen since the beginning of the pandemic between cases and then deaths starting to go up 4 to 6 weeks later. And I also have to acknowledge that state trends are actually variable. There are many states that continue to show downward trends in new case reports, whereas there are others with significant surges. And I would highlight Michigan, New York, and New Jersey. Michigan continues to surge, and their ICUs are full. Their health systems are at capacity. And this is the fourth significant surge that Detroit has had. So there really doesn't seem to be much of an impact on what we would call herd immunity from previous infections in regions in which they have already suffered a large burden of disease. New York and New Jersey were surging, and they seem to be plateauing now. Relevant to us, however, Minnesota cases are rising significantly, and Illinois cases have increased 50% over the last 2 weeks, and deaths are beginning to rise in Minnesota and Michigan. And recall that the virus can cross state lines, state borders and county lines easily, and that we are not an island here in Wisconsin. So what happened 2 to 4 weeks ago in the states around us should serve as a lesson to what could happen here in Wisconsin. And I would say the variability in what's happening in these different states probably has a lot to do with the emergence of new variant strains of the virus. So we have competing forces now that will dictate what happens here in Wisconsin over the coming weeks and months. On the one hand, we have increasing COVID-19 vaccinations, and I would hope restored confidence in the safety and efficacy of the vaccines. On the other hand, we have pandemic fatigue and the spread and here in Wisconsin of more contagious variant strains. Next slide, please. I do want to say that we are doing quite well in vaccine distribution in Wisconsin. As of yesterday, we were 10th of 55 states and territories in the US, both for a single dose and for completed courses, and 37.4% of the population of Wisconsin had received at least one vaccine dose as of yesterday. And you can see that on the right with the screenshot from the Department of Health Services website. And that translates to about 2.2 million people having received at least one dose in Wisconsin. We're doing pretty well in the US also. 1 in 3 US citizens have received at least one vaccination. And most of you know that the Milwaukee area was lagging in terms of vaccinations, especially in zip codes that had high populations of Black and Brown individuals, but we are catching up. And I want to basically thank the leaders in the region for acknowledging the problem and for addressing it head on, in particular with partnerships of the leaders of 10 Milwaukee area zip codes that have been made eligible to receive vaccines. Now, we are doing well in the US with nearly 3 million shots per day on average over the last week. In Wisconsin, we're also doing well. We had almost 400,000 doses last week, and our capacity and throughput for vaccines will never be a limiting factor here in Wisconsin. Really, it is a supply issue for us. I think we could crank that capacity up even higher than 400,000 per week. Next slide, please. Now, please bear in mind that this slide was submitted yesterday before the news about the Johnson & Johnson vaccine pause. But what I can say is that we have 3 vaccines that are authorized under the EUA mechanism from the FDA in the US. The Pfizer and the Moderna, which are messenger RNA vaccines that require 2 shots. The Pfizer's approved for individuals 16 and older, and they have asked or requested emergency use authorization for individuals 12 through 15 as of last Friday, and hopefully the FDA will act promptly on that request. Moderna is approved for 18 and older, both are 2 shots, and Johnson & Johnson is a more traditional vaccine using an adenovirus vector, a common cold virus vector, to introduce the snippet of the genetic information from the virus. That requires 1 shot and is approved for individuals 18 and older. Despite the pause in Johnson & Johnson distribution right now, all 3 vaccines are very effective in preventing the things that matter, which are severe disease, hospitalization, and death. And all 3 are very safe if you look at the number of side effects that have happened. I think the pause in Johnson & Johnson is a very responsible thing to do, and I'm going to talk about that later, and I already see a number of questions in the Q&A box. The next slide, please. So this slide basically talks about vaccine confidence. I just want to start by saying, as of yesterday, 788 million COVID-19 vaccine doses had been administered worldwide, with very few significant side effects reported. The US is first in the world for total vaccinations at 187 million and counting. Will pass 190 million today. And we have a higher percentage of individuals who've completed the series, 22%, than most of the rest of the world. Now we're behind some smaller countries, Israel at 56%, Seychelles at 41%, Chile at 25%, Bahrain at 25%, San Marino at 23%, and Monaco at 23%. But in terms of developed countries with large populations, we're doing extremely well. Wisconsin does have a higher percentage of individuals who've received at least one vaccine dose, and that was 37.4% yesterday, than much of the rest of the country, and we're on par with or better than our neighboring states. And again, I want to talk about the 3 authorized vaccines in the US. These are very effective and they're very safe, notwithstanding the concerns about the Johnson & Johnson vaccine. And we can't really directly compare them because there's never been a side-by-side study done. And for people that are still trying to shop and compare between the 3 vaccines, we really have to say that the efficacies are equivalent. They really all do give very outstanding protection for the things that matter. All of them show some reduced effectiveness against some of the variant strains, but they still give robust immunity. If I can go to the next slide, please. I'm not going to go through this, but I would just say congratulations to all of us in Wisconsin. We've opened up the eligibility in priority order, and as of April 5th, expanded eligibility to individuals 16 and older. Anyone who wants to have the vaccine is eligible. Children between the ages of 16 and 18 do require parental consent, however. So we can go to the next slide, please. So again, and we've talked about this before, when can we do the things that we miss? So I think there are 3 criteria that we need to think about. Most of you know about herd immunity, which is probably going to be achieved when we have 70 to 80+% of our entire population, and that includes adults and children, who've received a jab in the arm. And this is a potential challenge for us. If you think about it, 20% of Wisconsin's population are ineligible children. In other words, kids under the age of 16 who currently can't get the vaccine. So in order to get close to herd immunity, we would need every adult to agree to get vaccinated. And when we shift from a supply limitation to convincing people that this is a good thing to do, we're going to need to really have those kids in the pool of eligible vaccinated if we're going to get close to herd immunity. Jabs in arms is only one part of that, though. The burden of disease has to be low in all of the counties of DHS. And I really need people to understand right now, despite the fact that we have a lot of positive trends that we've celebrated over the last month or two, that we do not have a low burden of disease in most counties in Wisconsin. None were characterized as having low activity levels as of last Wednesday's report. And that's in contrast to last month when we were averaging 3 to 4 counties that had low activity levels. 10 counties have medium activity, 61 counties have high levels, and one, St. Croix, had very high levels. And there were no counties last month that had very high levels. So the trend and the trajectory of the disease activity actually is ticking in the wrong direction. And then finally, we need to know more about the effectiveness of the vaccines for the new strains and how well previous infections prevent reinfection. So I just want to talk about 4 of the strains. The Brazilian P1 strain is of concern for reinfection. And we're seeing in Brazil a huge surge of infections that is being driven by this P1 strain, and it's infecting many people who had a previous infection. So the durability and the vitality of previous infection immunity isn't particularly good against the P1 strain. And the P1 strain is infecting younger people and making them very sick. South African, or the B1351 strain, is of concern because it appears to be the strain that is most likely to have some partial escape from vaccine immunity. Although, again, I want to stress that the currently available vaccines on the market in the US do give reasonably good coverage against this strain. Now, 4 P1 cases have been detected in Wisconsin, that's the Brazilian strain, and 15 cases of B1351, or the South African strain. Interestingly, 148 cases of the UK strain, which is more contagious and now recently has been shown to cause more severe disease and to be more lethal, have been detected. And that was the strain that we thought would be the predominant variant strain in Wisconsin sometime in March or April. Interestingly enough, though, a larger number of cases have been detected by surveillance of a new strain, the B14.27 or B14.29 California strain have been detected. And I do want to say that there is emerging evidence that that strain is much more infectious or much more contagious, and was the reason that California had such a huge surge back in February, and that it may be more lethal. Certainly the burden of intensive care unit stays appeared to be much more significant when this strain was predominant in California. And so that is something that should be of interest to us. I also want to point out on the right-hand bar, in the green bar, that the CDC recently released classifications of variants by levels of concern. So variants of interest would be strains that have specific markers, probably on the spike protein, that would be predicted but not proven to impact biology. Variants of concern would be strains that have evidence of increased transmission, virulence, or possible escape from immunity. And all 4 of the strains that I have just discussed fall in that variants of concern category. And then variants of consequence would be strains that have clear evidence that prevention or treatment measures are largely ineffective. And fortunately, we have no strains that are characterized as variants of consequence yet, but we do need to maintain our vigilance. If I go to the next slide, that's probably the single best reason and the easiest to explain for why, even if you've been fully vaccinated, we still need to practice good behavior just in terms of trying to prevent the spread of disease. So continue to wear masks, watch your distance, wash your hands, and try to reduce non-essential trips outside the home. And go to the next slide. This simply shows the data sources that we use for the presentation. And before we go to questions, I do want to address what we do know about the Johnson & Johnson hold on vaccinations. So as of yesterday, the FDA announced a pause on vaccinating individuals with the Johnson & Johnson vaccine because of a very rare side effect called cerebral venous sinus thrombosis, or CVST, that's also associated with low platelet counts. This is actually similar to clotting disorders that have been reported for the AstraZeneca vaccine. So as of yesterday, more than 6.8 million doses of JNJ and Janssen vaccine have been administered in the US, but the CDC and the FDA are reviewing data involving 6 US cases of this rare severe type of blood clots in individuals who've received the JNJ vaccine. In these cases, a type of blood clot, as I said, called CVST, were seen in combination with low levels of blood platelets. So if there's only one in a million of these that have been reported, why did the FDA pause? First of all, I think the reason was to make sure that we knew exactly what was happening in terms of the numbers of cases. Just because 6 cases have been reported doesn't mean that there might not be others. We also know that these cases have impacted largely women between the ages of 18 and 48. Again, very similar to what was reported for the AstraZeneca vaccine in Europe. And the symptoms occurred within 2 weeks or within 6 to 13 days after vaccination. So anticipating questions, when am I out of the woods if I received a J&J vaccine? Probably 2 weeks out, you're fine. Now, the second reason for the pause is that the treatment for this type of disorder, when there are low platelet counts, this could be called something that we call a consumption coagulopathy, is different than the standard treatment for blood clots. In other words, if you give heparin when there are low platelet counts, you can actually make the problem worse. So it's important to pause so that we can make sure not just that vaccinators, but anyone that might encounter a patient that has a blood clot who could have been vaccinated recently understands that you might not want to give heparin. And so I'll stop there, Steve, because I know that there are quite a few questions in the box about this and other matters.
Great. Well, thank you very much, first of all, Dr. Raymond, always informative. Let's start with a question about with the pause in J&J. You mentioned how Wisconsin's doing well and how some of the supply problems we were encountering early seem to have worked themselves out, though, as another question says, there are pockets where apparently it's still hard to get to. What is taking J&J offline do for availability and accessibility of the vaccines in general in Wisconsin?
Well, I would start by saying that I'm only speculating because it really depends on how long this strategic pause goes on and what the conditions will be imposed if the J&J vaccine is released to the market again, and we don't really know when that's going to be. I would, now having said that, unless there's a very long pause, I don't think that the impact is going to be significant just in terms of the supply, because we already had a problem with 75 million doses that had to be discarded because of a manufacturing issue. And so we already knew that there was going to be a 3 to 4 week delay in beefing up that supply chain. Assuming that J&J is approved again for distribution, I don't think the impact is going to be significant. I still think that every eligible person in Wisconsin who wants to be vaccinated will be able to be vaccinated by the end of May. That's my best guess. I think the larger issue, though, has to do with vaccine confidence. As we know, the AstraZeneca vaccine is effective. It's largely safe, but people are concerned about these rare clotting events. And there has been some hesitancy in Europe in particular, in many countries, because of the uncertainty about the blood clotting. Just a couple of things, and again, I'm not trying to twist arms, I'm just trying to give you facts, that this is a very rare potential side effect of the AstraZeneca and the Johnson & Johnson vaccine. But just in terms of background amounts of clotting that happen in the general population, there's no significant increase with either of these vaccines. So we're really talking about this ultra rare potential side effect and not broad-based clotting disorders.
Great. Another question that was that I don't know if you guys are tracking this statewide, but are we seeing any areas where we're lagging in vaccine availability, or is vaccine availability pretty strong across Wisconsin?
Well, I'll start by saying in general, vaccine availability is strong in Wisconsin, but the areas that still continue to struggle and may be impacted by the lack of availability of the J&J vaccine, at least in the short term, would be rural communities and under-resourced urban communities, like the 10 zip codes in Central City, Milwaukee, that were made eligible to receive the vaccines earlier before we had broad availability for 16 and older. That's a problem because in those communities, it's difficult to take care of vaccines that require ultra cold chain transportation and storage. And so it's more difficult to administer them, say, at your local pharmacy or at a neighborhood church or community center. And it's also more difficult to administer those fragile vaccines at mass vaccination sites. Again, though, I do believe that because Moderna and Pfizer have both created extra manufacturing capacity for the messenger RNA vaccines, that we're still in pretty good shape.
A question you had said early in your presentation, and when you noticed that cases are rising, you wouldn't qualify them as a surge or a spike right yet, but they are something we want to keep an eye on. As local governments look at how they respond with their local health orders, we're seeing a lot of variety from community to community. What's the appropriate response to one of these gradual but not dramatic increases in terms of local health orders or what your recommendations would be on there? And it's particularly, I think, problematic for the health departments when the tools they have impact individual sectors like restaurants or schools or, you know, gatherings, but we don't necessarily in the tracing see that those are where the outbreaks are originating from. So what's the appropriate balance of concern and openness right now?
It's such a difficult question, Steve. Let me go back to the science and the facts. What we know is that the more people that wear masks, the more people limit non-essential activities outside of the home, the more people that maintain a safe distance, the better the impact is in slowing the spread of disease in our communities, whether that's by voluntary action or by policy interventions from the government, they work. The problem is we're 13 months into the pandemic. There's fatigue, there's politicization of these interventions, there's skepticism, and we're not really able to have a civil discourse. And I believe it is possible that the people who are going to adhere to these guidelines are going to do it voluntarily, and the people that aren't going to do it probably aren't going to be significantly influenced by public health interventions. You know, the businesses obviously are going to probably comply, but individual behavior is probably the most important aspect. And I think it's fascinating if you look at Michigan, who really tried very hard to have stringent public policy interventions for a long time. They basically have said it's too little, too late, and people are too fatigued, and they're appealing to individual behavior rather than policies. So I know I didn't give you a straight answer because there is a political aspect to this. But again, I would just appeal to everyone to follow the science and to not celebrate prematurely. And I don't want anyone to misinterpret what I've said about saying we're not yet in a fourth surge here. If the numbers continue to increase in the next few weeks, if the death starts to climb rather than being stable at 5 to 6 per day in Wisconsin, if our hospital censuses continue to go up, which they have for the last 2 weeks, then I will agree that we are in a surge. But I'd like to see what happens over the next 2 weeks.
Great, thanks. Maybe we'll wrap up on this one, and I'm going to appeal to your bedside manner as a physician here. The J&J news, the numbers changing, I mean, we do seem to be on a psychologically taxing, if not physically taxing, roller coaster on COVID news all the time. How should we deal with this? I mean, as individuals and as communities, how do you deal with the news that we're seeing without going nuts? And how do you appropriately synthesize that information that we're bombarded with every day?
Well, it's so difficult to synthesize the information because we have so much of it that actually isn't well curated. And that's mostly on social media, but also mainstream media sometimes shortens the headlines to something that actually causes people to misinterpret or overinterpret the facts. I think the most important thing is, you know, reach out to your network, especially to vulnerable individuals who may be bearing a disproportionate burden of the mental health aspects of this prolonged, difficult pandemic that we've had. And there's no good answer, but especially in the healthcare, the frontline workers, there's a lot of burnout, there's a lot of disconnection, there's a lot of frustration about how politicized public health interventions have been. And so we're trying in this virtual world to find ways to connect with each other. And Steve, just one more thing. And again, I don't want to focus on the negative, but just a cautionary note. What is different now than what we were seeing in November is the people who are getting sick are younger people. And these variant strains not only seem to be more likely to infect young people, but to cause significant disease. So we can't become complacent to think that we know everything about COVID-19 based on what was happening with a virus that was circulating in mid to late 2020, because things are different now.
Well, thank you very much, Dr. Raymond. As always, a font of great information for us to take with us. And I'd like to thank all our viewers and participants today. Thank you for joining us, and a special thank you as well to our sponsor, United Healthcare. Have a great day, a great week, and let's all stay safe. Thanks again.